All right. So I just want to take the opportunity to introduce our next speaker, Dr. Sunil Sheth, who is currently an assistant professor of neurology at UT Health. He was from Houston. He attended Harvard University as an undergraduate, where he graduated magna cum laude, and then stayed there for medical school as well, where he graduated magna cum laude. And during medical school, he also was enrolled in a collaborative program with MIT in health sciences and technology program. He was a recipient of a distinguished Howard Hughes Research Fellowship from the NIH. Ultimately, Sunil completed his neurology residency at UCSF, where he served as chief resident, and then completed 2 fellowships at UCLA in vascular neurology and interventional neuroradiology. And today he'll be speaking, as you heard, on do you need to really do CT perfusion in acute ischemic stroke? And with that, I'll hand it over to Sunil.
Okay, Amr, thanks for the nice introduction. So we're going to be shifting gears a little bit with spring break. So we had our first set of talks, which are really fantastic, on COVID and the relationship of COVID with stroke, and really great insights from those speakers. Now, the rest of the conference is going to be on kind of the hot topics and recent advances in stroke care, and this will be the first such session. Some of these topics will have some COVID-related implications, but the focus really will be now on kind of hot topics and recent advances in acute ischemic stroke. So this first presentation that I'll give is do you really need to do CT perfusion in acute ischemic stroke? Meant to be somewhat hopefully provocative. As Dr. Malik said, I'm a vascular neurologist and neurointerventionalist at UT Health, McGovern School of Medicine. Okay. These are my disclosures, some grant funding, but no conflict of interest with this presentation. So in this talk, I will go over imaging techniques that are frequently used for acute ischemic stroke. This will be a review for many of the practicing neurologists in the panel or in the audience, but we have a really fantastic number of trainees, and I think that hopefully this will be geared towards them to get a nice overview of what imaging we use and why. And then I'll go over what are the imaging modalities that were used in some of these landmark treatment trials, both for thrombectomy and for thrombolysis. And then I will present what I find to be the 2 main questions that neuroimaging needs to answer in the evaluation of a patient with acute ischemic stroke. And then from those 2 questions, we'll talk about the advantages and disadvantages of various different imaging approaches, including CT perfusion. And then we'll have a little summary at the end. Oops, too far. Okay, so the first imaging modality that we'll talk about is non-contrast head CT. This is the workhorse of acute ischemic stroke and the most commonly used imaging modality. It's widely available, it's inexpensive, it's rapidly obtained. We can do it on mobile stroke units, on the sidewalk. So it really is the most commonly used technique. But nowadays we have newer scanners, 640 detector rows that can image the whole brain in less than a second with very, very high resolution. And one of the main purposes of non-contrast head CT is the detection of intracranial hemorrhage. The clinical presentation between ischemic stroke and hemorrhagic stroke can really be indistinguishable. There are some features that can distinguish the two, but by and large, we need imaging to do that. And this exquisite sensitivity for non-contrast head CT really makes it an invaluable tool. And this is what I have on the slide here. So this image on the left is very obviously a patient with hemorrhage, is something that can be seen very readily, acute hematoma. But non-contrast head CT also has very valuable insights in patients with acute ischemic stroke. And we'll talk about some of those signs. So early ischemic changes can appear as loss of gray-white differentiation. So on this image on the right, it's more subtle, but this patient has suffered injury to the lentiform nuclei and the insular region. And as you look at these more and more, you start to compare one side versus the other. In this case, the left side, which is the affected side, against the contralesional right side. So there are these invaluable insights that you can get in ischemic stroke patients in terms of ischemic changes. You can also pick up chronic infarct, so areas that are much less dense on the CT. These chronic infarcts appear much more visibly apparent. And the other thing that you can see is the hyperdense artery sign. That's not a sign that always happens when someone has a large vessel occlusion. But when you see that, particularly, the bright appearance in the area of the middle cerebral artery or the ICA terminus, that gives you a lot more confidence that there is in fact a large vessel occlusion there. So there are many things that you can get. One of the scales that's very commonly used with non-contrast head CT is the aspect score, the Alberta Stroke Program Early CT score. It's a score that goes from 0 to 10, and you lose points for every region that's affected out of those 10 regions. And that's really become a very, very widespread tool that's used both clinically and on research studies to just quantify or just put a number to ischemic changes in stroke. There has been some work on windowing. So this 40-40 window has been used and shown that it can accentuate these the early ischemic changes on the parenchyma. So that's non-contrast head CT. It's really the most widely used study, and you can learn a lot from the brain in acute stroke on this scan. All right, so the next one we'll talk about is CT angiogram, or CTA. This is a contrast-based study. So a single venous bolus of contrast is given, and then once that bolus has hit the arterial phase, there's a single acquisition that goes either of the brain or from the neck all the way up to the brain to visualize the blood vessels. And that's the main purpose of this scan, is to visualize the blood vessels. There are other ways to do this as well, multi-phase CTA, where you acquire multiple phases of contrast, so you get some idea of the early arterial, early venous, late venous appearance. But the standard way to acquire CTA is with a single acquisition. Again, modern scanners are now much faster, and with these much larger detector arrays, we can image from the arch up to the vertex of the brain with one acquisition very, very fast and very, very accurate. It really reduces motion artifact. CTA sensitivity and specificity has been reported as 163% for extracarotid disease and up to 100% for intracranial disease in terms of large vessel occlusions. The other point that I want to make about CT angiogram with relevance to this talk is early ischemic changes, parenchymal ischemic changes, can be seen on CT angiogram as well. And there's a number of publications showing that CT angiogram aspects, or doing the aspect scoring off of CTA source images, can be much more accurate at depicting infarct core compared to non-contrast CT aspects, and that these CTA aspects correlate much more closely with MR diffusion images. Okay, so the next modality we'll talk about is Ct perfusion. So Ct perfusion is also contrast-based acquisition. A bolus of venous contrast is given, and then the same region of brain is scanned serially over time. And with these serial acquisitions, you can visualize the transit of contrast first from the arteries into the capillaries, into the parenchyma, then finally into the veins, and then out. And based on the arterial input and the venous outflow, you use computation to calculate cerebral perfusion parameters. And on the screen here are 4 of the most commonly used perfusion parameters, and that's cerebral blood volume and cerebral blood flow. These are the 2 metrics that are used most commonly for determining infarct core. And then mean transit time and Tmax, so the time to the maximum of the residue function, and these two, and mean transit time and Tmax, are used most commonly to depict the penumbra. So the ischemic core, again, is what we define as the area of the brain that is irreversibly injured or dead, essentially. And then the ischemic penumbra, which we're looking at with these bottom 2 scans, is what we think of as brain that may be dysfunctional or oligemic, but not quite dead. So this is tissue that, if you are able to reperfuse it in a timely fashion, should come back to life, and it's still vital. And as we'll talk about in the next few slides, CT perfusion played a massive role in the successful thrombectomy trials and also thrombolysis trials, and really made a big difference in terms of the success rates of these studies. We'll also talk a little bit about MRI. We had a little bit of mention of MRI earlier in this seminar from David Liebeskin at UCLA, which is a very big MRI center. MRI, and specifically diffusion-weighted MRI, is as close as we can get we think, to a gold standard in telling us about that true ischemic core. Diffusion-weighted imaging is a function of the random water motion in tissue, and infarcted tissue restricts the diffusibility of water, and that shows up on these scans as a brighter signal. There are several limitations to diffusion-weighted imaging, and there's data coming out about diffusion reversibility, so things that look bright, look ischemic or infarcted on the scan, but then you do imaging later on, and it turns out that it is in fact not infarcted. But we're not going to go into that in a lot of detail here. By and large, this gives us a very, very good visualization of the area of the brain that's irreversibly injured. This signal, this diffusion-weighted signal, is maximal around 40 hours and then fades away in about 2 or several weeks. There are a few other signs on MRI that can be useful in acute ischemic stroke, and that includes on T2 or flare imaging. You can see the absence of an arterial flow void, suggesting there's a large vessel occlusion. On iron-sensitive imaging or gradient echo imaging, you can see blooming of a artery, indicating there's probably a thrombus in there. And then also on flare imaging, we can see hypervascular or intravascular hyperintensity or bright signal in the flare vessels, particularly in the sylvian fissure, the MCA branches in the sylvian fissure, which we think of as either slow flow or retrograde flow, but again, indicative of a more proximal occlusion or severe stenosis. Another imaging modality that's also used is MR perfusion. I won't go into a lot of detail here, but it's another method that you can use in conjunction with diffusion-weighted MRI to tell you about the penumbra. So diffusion imaging can tell you about the core, ischemic core, and the MR perfusion can tell you about that penumbral volume. Okay, so I wanted to go through the imaging that was used in some of the pivotal endovascular stroke trials. And so on this table are 7 of those studies, both early and late window trials. And we'll talk a little bit about what imaging was used in these studies. All these studies were positive. All these studies showed that thrombectomy plus medical management was superior to medical management alone. And we'll talk about what imaging they used to define these patients. Imaging, we know, is a key criterion in patient selection. So the first study that was published, or sorry, first study that was presented was Mr. Clean. That was the biggest, the first, and really a landmark trial. It had 500 patients, and it was also the simplest in terms of what imaging that was used. It was non-contrast head CT and CT angiogram. There was no strict cutoff in terms of aspects or core. Aspects was collected, but that was after, that was not a part of the screening criteria for eligibility. So these are patients that had really minimal imaging, again, positive trial. The next 2 on the table are Dawn and Diffuse 3. These are the late window trials. Again, very, very positive studies. And both of these studies use advanced imaging. So both used either CT, CT angiogram, and CT perfusion, or MRI. And how they defined eligibility was a little bit different. So Dawn used what they called a clinical core mismatch. So conceptually, what that is you're using the imaging to help you define the ischemic core. And then you're using the clinical exam with NIH stroke scale to define the volume of brain at risk. So the greater the NIH stroke scale, the more volume there's at risk, with a greater penumbra. So the NIH stroke scale is sort of acting as a penumbral measurement in that sense. And so a mismatch between the amount of brain that's irreversibly injured and that penumbra is what was used to define patients in Dawn. Diffuse 3 was purely imaging based in that regard. It defined the ischemic core based off the CT perfusion and defined the penumbra also off the CT perfusion. And the imaging criteria were based on the mismatch between the core and the penumbra, both as a ratio and as an absolute difference. The next 4 studies were all early time window trials, so 0 to 6 hours. Revasca was 0 to 8 hours, but early time window. Escape used multi-phase CTA and a collateral assessment off the CTA, a little bit different than the other studies, and also the aspect score. Extend IA used CT perfusion. It was the smallest study, 70 patients, but still positive trial. And again, using that core and penumbra mismatch off of the CT perfusion. Swift Prime initially required CT perfusion, but then that was dropped, and it was aspects based, non-con CT and aspects based. And then Revascat was non-contrast CT in aspect space or MRI in aspect space. So aspects off of either CT, non-contrast CT or MRI. Okay, and this is a little bit more on the imaging characteristics, just going into some more of those details. In terms of the vessels that were included, because there is a relationship between how distal you want to go and those core penumbra ratios. But Mr. Clean allowed distal occlusions. They allowed ACA occlusions, including A2s and M2s. And as we mentioned, there was no specific threshold for aspects or core cutoff. Don, again, had this clinical core mismatch, which changed based on the patient's age. Diffuse 3 had a core absolute cutoff, and then also cutoffs relatives to the penumbra, meaning the ratio and the absolute difference. And then Escape had this aspects cutoff, and the others again use aspects as we discussed. Okay, so these trials resulted in an update in 2015 to the American Heart Association guidelines, and then also in 2018. So these are the most recent updated guidelines after Dawn and Diffuse were presented. And these guidelines say that all acute ischemic stroke patients should receive imaging, and this is to help decide on thrombolysis as well as distinguish between hemorrhage. And they say that most patients in this regard will receive non-contrast head CT. They also recommended for patients that, based on clinical exam, may have a large vessel occlusion and would potentially be candidates for thrombectomy, should have a CT angiogram or an MRA or non-invasive vascular study, which is CT angiogram or MRA for the most part. And then in patients in the late time window, which is 6 to 24 hours, who have a clinical suspicion of large vessel occlusion or CT angiogram evidence of, or vascular imaging evidence of a large vessel occlusion, they recommend either Ct perfusion or MR diffusion with MR perfusion. So either Ct perfusion or MR diffusion with perfusion. So that's imaging definition of tissue that's been injured and tissue that is at risk of being injured and dying. Okay, so that's the thrombectomy imaging data. I'll spend the next few slides now talking about thrombolysis imaging, because there's been a lot of progress and new data on new ways to do thrombolysis. So this was the Wake Up trial, which came to us from Germany. And the idea here was to expand the time window for treatment of patients with IV alteplase, particularly in patients who woke up with their symptoms. So these are patients who may have gone to bed, and when they woke up in the morning, they had deficits that they had not had when they went to bed. Or in general, patients that have unknown time of onset. They don't have to be asleep. They could be for other reason. We don't know their time of onset. And so the idea here was to use the MRI as the physiological clock. We know from previous trials that IV alteplase is beneficial in patients up to 4.5 hours from symptom onset. So can we use the MRI to time that 4.5 hour interval? And they did this by measuring a mismatch between two MRI sequences. So the diffusion DWI sequence and the flare sequence. So if we see the infarct on diffusion, but we don't quite see it on flare, these are patients that are probably within that 4.5 hour window, because the flare will turn positive around that time point. So this trial was a randomized placebo-controlled trial to say, if we give thrombolysis in these patients, is there an improvement in clinical outcome? This trial was ultimately stopped early because they ran out of money, but it was positive. So we can see on the next slide here, these are the clinical outcomes. So in the group that was treated with IV alteplase, there was a significant reduction in 90-day disability, and particularly growth in the independence or very mild disability. So MRS of 0 or 1, and this was a statistically significant improvement. The next thrombolysis trial that came out, again with this idea of expanding the time window for IV alteplase, was the Extend trial from Australia. So the idea here was to look from 4.5 hours to 9 hours after symptom onset, and to use imaging to help identify who might benefit from thrombolysis. This trial also included these wake-up patients, and the way they calculated the start time in those patients was basically midpoint between when they went to bed and when they found the symptoms. So that was assumed to be the start time, and then it was this 4.5 hour to 9 hour window. In this trial, however, patients were excluded if they had thrombectomy that was being planned, or if they had severe stroke or very mild stroke. And the imaging criteria on this study was CT perfusion with a core and penumbra mismatch using rapid. This trial was also stopped early because Dawn and Diffuse 3 came out, and there was a loss of equipoise because previous to those two trials, patients in the later time window may not have gotten treated with thrombectomy, but now that we could see there was clear benefit in these patients with the presentation of those trial results, these are patients that would probably just go for thrombectomy and not get this delayed time window thrombolysis or be eligible for this trial because of that desire. So this study was also positive, just barely, but there was an improvement in clinical outcomes at 90 days in the group that was treated with alteplase relative to placebo. And again, the main improvement here was in those 0 to 1 MRS groups. Okay, now the next thrombolysis trial we'll talk about is Extend-IA tenecteplase, also out of Australia. But this was not an extended time window. This is the same 0 to 4.5 hour time window, but tenecteplase versus alteplase. Tenecteplase is a novel thrombolytic agent and maybe more effective at thrombolysis than alteplase. It also benefits from being a one-time bolus as opposed to a bolus and a drip. In this study, patients had to have a large vessel occlusion, either ICA, MCA, or basilar artery, and they had to be candidates for thrombectomy. This trial initially required CT perfusion with a core and penumbra mismatch, but they had a hard time recruiting, so that requirement was dropped after about 80 patients. And again, the treatment arms was either one-time bolus of tenecteplase at 0.25 milligrams per kilograms, or IV alteplase in the standard bolus and drip format. In this study, the main endpoint was vascular reopening, so thrombolysis of the clot and reperfusion when the patient had their first angiogram, again, with anticipation of thrombectomy. So in this study, 10% of the patients that were treated with alteplase had reperfusion of the vessel or reopening of the artery, compared to 22% in the tenecteplase group, which is really kind of a staggering number. Over a fifth of the patients that got treated with tenecteplase, by the time they arrived for thrombectomy, there was no need to do thrombectomy because the vessel was already open. And this was a statistically significant difference with that primary endpoint, and then also on the clinical endpoint was a improvement with tenecteplase relative to alteplase. So we went through a bunch of trials just now, both thrombectomy and thrombolysis, that allowed both CT perfusion and MRI. So many of these trials, especially the late window trials or the late window or expansion of indications for thrombectomy and thrombolysis, use advanced imaging either with CT perfusion or MRI. But I want to just make the point that while both of these were allowed, by and large, these really were trials of CT perfusion. That was the main imaging that was used, far greater extent than MRI. So in the 7 early window trials with in the Hermes consortium, CTP was used in about 80% of those patients, compared to 21% MRI. That was the early window trials. Then Diffuse 3, which was a late window trial, CT perfusion was used in 75% of the patients. Similarly with Extend, 87% of the patients had CT perfusion. And then in FastMag, which was not a study of thrombolysis, a neuroprotective trial, but a nice data set that captures a number of patients that are thrombolysis eligible. 95% of them were screened with non-contrast head CT compared to 5% MRI. So in the community, the vast majority of thrombolysis screening is being done with non-contrast head CT, which I think is important when you think about what's the right way to image these patients. I think the availability of imaging or the capability of performing these studies is a very important aspect of that. Okay, so now I wanted to talk about my framework when I think about how to perform neuroimaging on acute ischemic stroke patients. What are we trying to do with the imaging we're performing? In my mind, I think there's two questions we're trying to answer for both thrombectomy and thrombolysis, so this extended thrombolysis. With standard thrombolysis, you really only need a non-contrast head CT to rule out hemorrhage, and then the rest is clinical. It's not really imaging based. But with thrombectomy or with extended window thrombolysis, I think there are really only two questions that need to get answered. The first is there a large vessel occlusion or not? And the definition of what is large vessel occlusion is a bit shifting. Initially, it was an ICA terminus or an M1. Now we're also including M2s and A1s and A2s and basilars and PCAs, and so that definition has been shifting. But the question is still the same: is there a large vessel occlusion? Yes or no? And if there is a large vessel occlusion, is there salvageable tissue? So that's the second question, and that's where more of the uncertainty arises. Is there salvageable tissue? And I think there's two ways to do that. One is by imaging. You have an imaging definition of core, and you have an imaging definition of penumbra. And the salvageable tissue is the difference between the penumbra and the core, or the at-risk tissue and the core. The other way to do that is with imaging and exam. So that was what we mentioned about the Dawn trial. You have the ischemic core, which you can determine based off imaging. And then you have the NIH stroke scale or a clinical exam, which gives you a sense of how much brain is dysfunctional, which is the amount of brain that is presumably at risk of dying. And so these are the questions I think need to get answered when you're imaging a patient for stroke. And then for the rest of this talk, we'll go through different imaging possibilities and what the relative advantages and disadvantages are in terms of answering these questions. All right, so first we'll talk about Ct perfusion. And we talked about that. It played a very, very large role in these clinical trials. And what's the advantage of that? Well, I think the first thing to look at is just look at the trials that had very high Ct perfusion rates and their rates of good clinical outcome. So it was the same table as before. I just added another column here with the modified Rankin score or the rate of functional independence at 90 days. So the study with the most Ct perfusion or rate of Ct perfusion was Extend IA, and 71% of their patients had functional independence at 90 days. These are patients with a severe stroke, large vessel occlusion, and in a trial that only had 70 patients, they achieved statistical significance because there was such a dramatic improvement in the patients that got thrombectomy that had Ct perfusion. Same with Swift Prime, very high rates of outcome. Again, not as much Ct perfusion because it was dropped during the course of the trial. And then the late window trials, again, had very high rates of good outcomes, close to 50%. And then the trials that had less Ct perfusion, Mr. Clean and Ravascat, had lower rates of that functional independence. So one of the big arguments in favor of Ct perfusion is look at how good you are at selecting who's going to do well from thrombectomy based on these trials. I think another advantage of Ct perfusion, and we'll see this on the next slide, is there are now many different ways to do automated post-processing, or many different vendors that can offer automated post-processing. So you acquire these images, the image gets sent automatically to these software packages, they process them automatically, and then it gets sent to you either on your phone or your email with very clear pictures of what the core looks like, what the penumbra looks like, and essentially telling you, yes, this is a thrombectomy candidate, or no, this is not a thrombectomy candidate. So that ease of use, I think, has played a large part in the popularity of the software as well, because it's been very pleasurable to implement. And also, I would say that I think that there is, based on these trial results and also from other studies, there is probably a more accurate depiction of ischemic core on Ct perfusion relative to non-contrast head CT. This is what a very common or popular imaging workflow looks like when evaluating someone for a thrombectomy. You come in, patient comes in, they first get a non-contrast head CT, that's this image on the top left. You see that there's no blood, and you give them thrombolysis. You give them IV TPA if they're eligible for it. Then you do a CT angiogram and you see, look, there's an ICA terminus or M1 occlusion. This is someone who may need a thrombectomy. They then get a Ct perfusion. The Ct perfusion tells you, gives you a sense of how much tissue has died. That's the pinkish area here. And the substantially larger portion of the brain that is at risk of dying, but not quite yet dead. This is a signature that makes one think that reperfusion with thrombectomy would be beneficial to the patient. They then go to angiogram. You see the occlusion, you remove the occlusion, and then you may have an MRI down the road a few days later showing the final infarct, and the final infarct, ideally matches up well with what you had seen on the initial scan, that Ct Perfusion when they presented, and that tells you that you had halted the arrest, you had arrested the progression of the infarct by giving thrombolysis and by doing thrombectomy. So this is a sort of Ct Perfusion workflow that I think is very popular and commonly used. Okay, so based on the title of my talk, we're going to focus a little bit on some downsides to Ct Perfusion. So the first is there are several technical considerations when you're doing Ct Perfusion that shouldn't be overlooked, and that is you really need to have an optimal contrast bolus. So that's something that you can see by looking at the time density curves or the arterial input functions, the venous outflow functions. You really need to see those time density curves clearly and in their completion. If you don't have that, and you cannot have that for several different reasons, your results are not going to be accurate. So that's something you just need to think about whenever you're acquiring Ct Perfusion. Another issue is patient motion is often an issue, and these software packages all include some motion correction, which address that partially. But in some of these published studies, up to a quarter of the patients, 25% of patients that got Ct Perfusion, the images were not diagnostic because of movement of some kind. The next, and we'll talk about this in the subsequent slides, is that there's some concern that Ct Perfusion may overestimate or underestimate core. I think that the key thing to keep in mind is that Ct Perfusion is not sort of push button acquisition in the way that you think of other ones like CT angiogram or non-contrast head CT. Now there's also some subjectivity in those acquisitions, but Ct Perfusion much more so, depending on how the contrast is given, how the raw images are acquired, but even more so how the post-processing is done. You can get very, very, very varied results. So it's not a sort of one size fits all. I push the button. This is what Ct Perfusion says. It really depends on how you set up your parameters and how you do your post-processing. So based on how you do that, you can really overestimate or you can really underestimate both core and penumbra. And then also just keep in mind that there are specific stroke subtypes. For instance, lacunar infarct, Ct Perfusion is not going to be very helpful. Posterior fossa, where there's a lot of bone and non-contrast head CT has a number of limitations in any case. And if there's a lot of white matter disease, that's going to be confusing for perfusion. Getting to this point of uncertainty around definitions of core, there's some data coming out that's been out that perfusion may overestimate core in certain settings, and underestimating core to a certain degree is not as grave of a sin, because the problem you run into there is maybe over-treating, but under-treating is probably a worse thing to do than to over-treat. So overestimating core is a bigger problem. And that, again, is because perfusion of the brain is dynamic. So even if your perfusion works perfectly and you are, in fact, capturing very accurately the relative blood flow and the relative blood volume, when someone has an acute occlusion, that's going to fluctuate with time significantly. So this kind of static image you get now is not necessarily representative of what's going to happen 5 minutes from the time that image was acquired. So this was a study from Mark Rebo and his group in Barcelona that coined this concept of a ghost infarct core. So what they have here is perfusion maps of both blood flow and blood volume on a patient with a right MCA occlusion. Based on really any kind of parameter or any kind of thresholding or parameter you choose, you would say that this patient has infarcted much of the right MCA territory. There's total collapse of the blood flow and blood volume maps. This patient went on to get thrombectomy, and then when you look at the final infarct on follow-up, there's almost no infarct on the CT scan. So are we overestimating core by CT perfusion in certain settings? This is what the ghost core concept is bringing out. The other aspect of perfusion is the penumbra, right? So the penumbra, I think, doesn't get talked about as much, but that penumbra volume really plays a very important role in your decision making about whether you're doing the thrombectomy or not, because when you're measuring the mismatch ratio, that's what you're comparing against. Is there a big mismatch against the penumbra? So if your penumbra is off, particularly if it's underestimating the true penumbra. That's an issue. So this was a study that we did where we had the great fortune of working with the Mr. Clean group. So Mr. Clean again was the first thrombectomy study that was completed, and I think is a very valuable data set because it's probably going to be the only one moving forward where we have a true sense of the natural history of MCA occlusions or ICA occlusions. Nowadays, if you have an MCA occlusion, you present early, you're probably going to get a thrombectomy. So it's much harder to see how the MCA infarcts progress over time. But in this study, we were able to use the medical arm of Mr. Clean, so people that came in with large vessel occlusion that did not get thrombectomy. And also we included the ones that got thrombectomy, but it was not successful. So patients that did not get successful reperfusion. And we asked how accurate was CT perfusion at measuring the penumbra in the sense that how accurate was it at telling us what is the true extent of the tissue at risk. And so what we showed, or what we saw was, if you plot the predicted at-risk volume, as we do on the figure on the left, against what ends up being the final infarct volume in these patients that did not get reperfusion, there's almost no relationship between the final infarct volume and this at-risk prediction. But again, if you had to err on one side, you can kind of explain why the at-risk volume may be, or the final infarct volume may be smaller than the at-risk volume. Some of these patients got TPA. There's also spontaneous recanalization. So if the final infarct is smaller, that's somewhat explainable. But what is less explainable is why would the final infarct be bigger than the volume that you predicted based on the perfusion? And we saw instances of that. An example of that is here on the right. So the yellow color here is what was the Tmax volume, or predicted to be the tissue at risk. This patient did not get reperfusion. And then the final infarct volume is not only bigger, but there are regions of it that are circled here in red, which were never predicted to be at risk based on CT perfusion, but have actually infarcted over time. Okay, now the other disadvantage of perfusion that I want to mention is something that has been called the fast progressor paradox. So this is a thought and data that's come from UPMC in Pittsburgh. They've been thinking about how infarcts progress over time in patients with large vessel occlusion for quite some time now, and quite deeply. So they've made this concept of two different phenotypes of progressors. You have fast progressors, who are patients that with a large vessel occlusion, even if they present in the early time window, really rapidly after their stroke symptom onset, already develop a massive infarct. So presumably they have very poor collaterals, or for other reasons, their stroke grows very quickly. Their brain may be less tolerant to oligemia. But these are the fast progressors. So their rate of neuronal loss is far greater than that 2 million per minute that gets quoted so much. Then on the opposite side, you have the slow progressors. So these are patients that have a large vessel occlusion, but that infarct grows very, 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 very slowly over time. And they go out to, 12, 18, 24 hours, and the infarct is still growing very slowly. So these are the opposite phenotypes. They have very good collaterals. Their brain is more tolerant to oligemia. For whatever reason, they progress very slowly. Now, the paradox when it comes to CT perfusion is this. When someone comes in and we see that there is some evidence of early ischemic changes on the non-contrast head CT, but we're not really sure if that's the true representation of the real infarct core, CT perfusion is often used in that setting. We want to say, well, let's get a real good image of what the core actually is before we decide to treat these patients or not. But the irony is, if this patient is presenting in the early time window and they already have a decently established infarct core, they must be a fast progressor, sort of by definition. And if you are taking additional time to do a CT perfusion, you are potentially harming that patient by delaying their reperfusion. So if you are taking that time to do the perfusion, there's more tissue that's dying. These are patients that every minute matters, 3, 4, 5 times as much as it would the slow progressor or maybe even the average progressor. So that's that paradox where you use perfusion because we think the patient has a larger core, we feel the need to visualize it, but in doing so and adding in those extra delays, we may be causing harm to the patient. Okay, so that was perfusion. Now let's talk about non-contrast head CT. So what are the advantages of non-contrast head CT as your workhorse to define core, ischemic core? The first is we talked about non-contrast head CT is everywhere. You can do it anywhere. You can do it in MSU, at McDonald's. You can get it very easily. Pretty much any hospital that sees stroke patients can do a non-contrast head CT. Another thing is there are increasing numbers of automated aspect scoring softwares available. So aspects, it takes a little bit of training to get consistent and reduce inter-rater reliability. But there are more and more automated aspect scoring softwares coming out. And then the other piece of this is if non-contrast head CT underestimates core, the only sort of sin that will be committing would be over-treating patients and less likely to be under-treating patients based on non-contrast head CT findings. Okay, but what are some of the disadvantages? The first is, as we mentioned, looking at CT for subtle early ischemic changes accurately takes experience. And I can tell you when we have our stroke conference here and we show up, we flash a non-contrast head CT, everyone has a different aspect score for what that is. Like, oh, I think that's that. I think it's not that. So taking time to really kind of look at these CTs and get consistent with the way that you read compared to consensus takes time, and it's not a sort of immediate skill that people can gain. And we said it's not as visually obvious as a post-process CT with these beautiful pink and green images. And also, to be clear, it's not a guideline-based criterion for late time window patients. The guidelines still say to use CT perfusion or MRI for thrombectomy decision making in those patients. Okay, but how important is core prediction? So this was a study which was a post hoc analysis of the Mr. Clean study from Albert U, where he looked at patients that had lower aspects. So we think that if you see it on CT, it probably is in fact dead. So patients with aspects of 5 to 7 or have at least that much tissue dead, maybe potentially more. And suppose that you thought that this patient had really good aspects, but in fact is a little bit lower because you're not so good at looking at aspects. Are you harming the patient by taking them for thrombectomy? And when you look at patients that had aspects even as low as 0 to 4, which is a massive infarct, the rates of hemorrhage were no different than patients that had aspects of 8 to 10, meaning very, very little infarct. So the likelihood of causing harm, even when someone has a massive massive infarct, is very low based on these data. And this is just showing that even patients with relatively moderate size infarcts, these aspects 5 to 7, there is a suggestion of clinical improvement in outcome with thrombectomy. This is a question that is going to be looked at in more detail with ongoing clinical trials. So the Tesla trial is looking at patients with those larger cores defined by aspects. And the tension trial, again, larger core defined by aspects, and the last trial also larger core defined by aspects, either non-contrast head CT or MRI. But again, there's this idea that you're using CT. There's no need to do perfusion in these patients because you want these larger core patients to see if there's any injury by doing thrombectomy or harm caused by thrombectomy, and potentially there may be some benefit. But especially for patients that are presenting early, that additional imaging with perfusion, are you gaining anything? If you see someone with a large core, you already know it's large core, and additional time may be particularly harmful in these patients. Okay, but now, what about the late time window? Because the guidelines are clear on that the data for this clearly are restricted to patients that have advanced imaging with MRI and MR perfusion or CT perfusion. So this was a study from the German group, Simon Nagel and his group, where they took all the patients that did thrombectomy on up to 24 hours from onset with LVO. They got thrombectomy. And to make a long story short, they saw that the patients that got thrombectomy in the late time window, more of those had CT perfusion and MRI, as you'd expect. But having had MRI and CT perfusion made no difference in outcomes, and that aspects was just as good at predicting outcome in early window patients as well as late time window patients, and that the addition of perfusion and CTP in this multivariable regression contributed nothing to predicting improved clinical outcome. So I think there's sort of a philosophic change in my mind, which to answer this imaging question, when you're asking the question, what kind of imaging do you need? I think the philosophical question is, well, what question are you trying to answer? Is your question, will this patient achieve good neurological status, meaning functional independence with thrombectomy? And if you want to only get patients that are going to get very, very well after thrombectomy and get functional independence, then maybe you need more selection with more advanced imaging. But if your goal is, will this patient have reduced post-stroke disability with thrombectomy, or will this patient be harmed by thrombectomy, maybe this advanced imaging is not as necessary. The other thing that comes up, particularly for patients, for the attendees that are not interventionalists themselves, or work in centers where they're sort of guiding the care, is, well, what do your interventionalists want? Some interventionalists say, I want perfusion, I want to know exactly what I'm doing, and I want to know that this patient is going to jump off the table and give me a high five. That's another consideration, but I think you also have to ask yourself, is that correct? Okay, so for the last few minutes here, I want to save some time for questions because I see there are a good number coming in. Is CT angiogram and CTA aspects, which I mentioned before, but CTA, so doing aspects off of CT angiogram source images is a better way to predict infarct core than non-contrast head CT. And this is a study in AJNR that did just that. So on the left figure, they plotted the presentation aspects versus the final infarct aspects. And on the right figure, they plotted the CTA aspects against the final infarct. And as you can see, the CTA aspects correlates almost perfectly with the final aspects. So just showing that based on that initial scan, CTA is more predictive of what the final infarct will look like in patients that got thrombectomy and their infarct presumably froze with reperfusion. Disadvantages of this approach, again, there's a learning curve here. I think if there's a learning curve for non-contrast CT aspects, there's a steeper learning curve for CTA aspects. It's not commonly done. This doesn't show up frequently in radiologists report off of CTAs. They don't read CTA aspects, whereas they may read non-contrast head CT aspects. So it's not as pervasive of a thing that's done. And in the last 2 minutes, I will talk about some of my own research interests in this area, which is using machine learning to take what we have learned about the advantages of CTA aspects and perform automated reads. So what we try and do, and this is, let's go ahead here, is, and this is, by the way, not my work, this is the work of Dr. Giancarlo, our computer science colleague, was to take CT angiogram images, raw images, and then to take CT perfusion images that were simultaneously acquired and post-processed, and then feed them into our algorithm, and then tell the algorithm to read the CTA images and predict what the CT perfusion was going to show. And the purpose of this, again, is because we think that the real representation of ischemic core is there on the CTA, and we can see that on the previous slide about CTA aspects being pretty accurate. So the data are there, and so can this algorithm predict what is there, with the CT perfusion being the gold standard? This is a slide that shows the performance of the algorithm. On the left is these are all receiver operator curves, and the lines here represent we asked it to do two different thresholds, basically the two criteria for DON, which was a 30 cc and 50 cc cutoff. So the algorithm performed very, very well, to make a long story short, both in the early time window and the late time window, which gave us the reassurance that on CTA, there's a lot of data there that will tell you what the ischemic core is, that is very, very accurate compared to CT perfusion, and that you can use machine learning algorithms to give you the same types of results, but again, using CT angiogram, which is a much more readily obtained imaging acquisition. So I will stop there and summarize, but just to go through what we talked about, advanced imaging played a key role in the early and late window time trials for thrombectomy. It also played a very key role in the late window and novel agent thrombolysis studies. There's new data emerging around the safety of thrombectomy without advanced imaging. And the advantages of not doing CT perfusion is that you can have a much more simple and faster screening mechanism. But we need more data around late window thrombolysis and around late window thrombectomy with this more simplified imaging approach. All right, with that, I will conclude and look forward to the questions from the group.
Great. Thank you for that excellent talk, Sunil. The first question, just more of a logistical question. Some centers have different approaches to how they perform their CTP in sequence. Some do CTA followed by the CTP, some do CTP followed by the CTA. Do you have a preference or recommendation on which is more ideal?
Yeah, that's a great question. We have multiple centers that do CT perfusion and multiple ways of doing it. So at one of our centers, we do the CT angiogram first, then the CT perfusion. The advantage of that is that you can kind of make your decision up front, right? You see there's an LVO and you can kind of get everything ready, and the CT perfusion is kind of cooking while you're getting the room ready. The disadvantage of that is sometimes that contrast data you've been given with the CTA will interfere with the perfusion acquisition. I've heard sort of both ways in terms of whether that makes a big difference or not. I haven't seen a big difference, but I know some people are very upset by that. At other centers, we do the CT perfusion first and then the CT angiogram for that reason.
Okay. And another question that came in from multiple folks. Do you do CTP as part of your standard acute ischemic stroke approach? Do you do it on everybody, regardless of last known normal time, or do you have certain time criteria that you adhere to? For example, one person asking the question at their center, they utilize CTP when the patient presents between the 4.5 to 24-hour window after last known normal.
Yeah, so that's a great question, and that's sort of the question I was trying to address with this talk. But there are many ways to do it. Again, so we have multiple centers, and they do it different ways. So where I am right now at our academic center, essentially every patient gets CT perfusion unless there's some reason not to get CT perfusion, kidney issues, or they can't sit still or that kind of thing. That's early and late time window. At some of our other centers where we also do thrombectomy and our comprehensive stroke centers, we've moved almost entirely away from doing CT perfusion, even in late window patients. So that's, again, going off of data like we showed here from Simon Nagel, also some of the data from some of the registries like NASA and Stratus. These registries also showed safety and efficacy in that type of a screening approach. So I think how you set up your imaging approach ultimately gets very tailored to your individual site and the preferences of the interventionalists there and the neurologists there. But I think that there is sufficient evidence to support that full gamut of imaging approaches, doing CTP in all these patients. I think in the early time window patients, it's a little bit less clear, but I think it's still there because so much perfusion was used in the early time window trials. Certainly it's there in the late time window patients. But then doing the opposite of using very, very little CT perfusion is also, you can find evidence to support that approach. So I think that is a decision that gets tailored to each site, and there's many, many right answers.
Okay. And sort of along the same logistical lines, do you have any sort of mismatch threshold that you use for making a decision on whether a patient goes for thrombectomy or not?
Yeah, so great question. So, I think that this is where we are moving away from, this is the difference between clinical trial and clinical practice, right? So clinical trials, which is a lot of what we talked about here, because that's what's published, is the purpose of a clinical trial is different from what you're doing in clinical practice. The purpose of a clinical trial is to be positive, and you set up your parameters so that you are going to show that your intervention is beneficial. The purpose of clinical practice is again, this is my view, is to decide whether or not you can help this patient improve their outcomes or reduce their disability after stroke. And so that's the question that I'm asking. So rather than following the mismatch cutoffs concretely or kind of in absolute terms, it's that more subjective question is based on the patient's history, exam, and imaging. Is this someone who would benefit from thrombectomy? They have mild symptoms, but they're concert pianists, or they are public speakers and they have mild aphasia. So these are the considerations that I think go into clinical practice, which is different than clinical trials. And again, when you're making a decision about thrombectomy, it's always a risk benefit cutoffs. So to expand on that, I don't in my personal practice feel that I have to follow the letter of the law in terms of what was on the guidelines, because there are data again to support your decisions, however you decide to go.
Okay. I had a few questions related around the use of CTP and potentially ruling in or ruling out stroke mimics. So I guess the question is, would you support the use of CTP to rule in ischemic stroke versus potential mimics?
Yes, so it's a good question. So one of the things I didn't mention about CTP is it can also help you interpret your CTA. So if someone is coming in and you kind of can't see this M2 occlusion, but you can see this big wedge-shaped area of hypoperfusion on the CTP, then you can go back and say, oh, there it is. I missed it initially. So that's one additional benefit. But I think the question is asking, if someone comes in with a seizure or a migraine, there are also characteristic changes on CTP, which cannot either be hyper or hypoperfusion, but there are some changes. I think that, as an ancillary study, if you find that helpful in your practice, I think it's a reasonable thing to do. I think there are other ways to do it too, with MRI or with a clinical exam and a history. So I think it has some utility. How to exactly be very, very confident that your CTP is telling you this patient had a migraine is not as clear, because those definitions are not as clear cut. But if in your practice it's helpful, I think it's reasonable.
Okay. And during the COVID-19 global pandemic, have you appreciated any differences in CTP abnormalities versus pre-COVID versus during COVID?
It's a good question. I'll tell you, in our practice here, we've been very fortunate where we haven't seen those strokes that they've been describing in New York and out of Sinai, where these very young patients with very hypercoagulable. We have not been seeing that. We've been doing basically the same number of thrombectomies that we were doing before COVID, and we've had patients under investigation, but no one that's been kind of COVID positive and very different. So I have not been seeing any differences in our patient population.
Okay. And there was a question about your thoughts on adding collateral imaging to CTP.
So there are several additional things that you can do to help improve your confidence in terms of core and likelihood of benefit. So collateral imaging is one. So and there are many ways to do collateral scoring. There's like 4 or 5 at least CTA collateral scores. There are also multi-phase CTA or multi-phase CTA scores. So I think these are all very helpful things. I'll tell you from a practical point of view, getting everyone trained where their aspects are consistent and the inter-rater reliability is low is kind of challenging enough. I think adding on additional scores, like picking a collateral score and doing that, or changing our imaging protocol to do multi-phase CTA and then having everyone kind of read that, is just kind of a challenge. And that's just, we have 10 hospitals with Dr. Wu's and Christie's telemedicine network that you guys heard about. We have 20 hospitals where we're seeing stroke patients. And so getting that kind of consistent across everyone in the system is just sort of a practical challenge. But if this is something that is something that you can implement, I think it certainly makes sense. I come at it from more of a practical point of view where it hasn't probably added enough value to be worthwhile for us.
Mm-hmm. And if CTP, this is a question from one of our international attendees, if CTP or MRP, MR perfusion is not available, would you then depend on MRI diffusion flare mismatch as the sort of next best surrogate for making decisions?
I assume for thrombectomy?
Yeah.
So I think if MRP and CTP is not available, then, based on what we were talking about earlier, I think that going off of CTA or non-contrast CT alone, either CTA aspects or non-con CT aspects, there are data to show that is sufficient. That you're not missing anything that would confer harm on your patient if you go that route.
Mm-hmm. Okay, and one other sort of as a follow-up to that, one question that was posed was a hypothetical. If you have a patient with an NIH of 4, greater than 4 symptoms, not specifically specified, but and the CTP showed no core, would you first, option 1, go for MRI for the DW flare mismatch identification, or would you stop and decide to give IVTPA assuming that the patient could have a lacunar or brainstem infarct?
So again, just going back to the original two questions, I think the first question is there LVO or not? So that's the first question. If there's an LVO, then we can think about thrombectomy. But before that, if someone is eligible for TPA, we give TPA. If this is a disabling deficit, and the definition of disabling deficit varies by the person in the deficit, then they should get thrombolysis. Then if there is an LVO, then we can think about thrombectomy. And now this question of a low NIH stroke scale thrombectomy is a very interesting one, and there are more and more data emerging from it, particularly from Emory, from Raul Noguera and Diogo Hausen, and more trials coming out. So endo-low will be coming out. So I guess if that patient has an LVO, our preference would be to enroll them in endo-low. But there are some data suggesting that the approach of kind of waiting and seeing on those patients may be less beneficial than treatment up front. But again, that's an open area of investigation.
Okay. Another, just the most recent question that was asked. Do you think that it might be better to consider a triple phase CTA rather than a CTP, just in the interest of saving time?
Yeah, I think multi-phase CTA gives you more information than CTA, single-phase CTA. Mm-hmm. What I think we're trying to show with the CTA aspects is that even the single-phase CTA probably gives you enough information. Again, there's a sort of balance between how much perfect information do you need versus you have enough information to make your treatment decision. So, in my view, and based on the studies that we were showing here, I think there's sufficient information in a CTA to feel like you can treat a patient, not be putting them at any additional risk, and potentially providing some benefit with thrombectomy.
Okay. And the last question that we'll ask, how do you see the future of acute neuroimaging evolving? Do you think it will transition more towards just MR-based, MR perfusion based on the high sensitivity, or kind of remain as is with CTP in utilization, or simply just non-con head CT and going to the angio suite?
Yeah, great question. Well, I think I've made my kind of view sort of clear on this, and so people will think differently. But I think that our field, vascular neurology, has been one of the first fields of medicine to really vigorously embrace machine learning. I think it's really hard to find other examples where we have AI helping us make decisions, providing clinical decision support on an everyday basis, as we do now with these software packages that we have that do Ct Perfusion automated analyses. So I think that the future is we're going to do more simple imaging, but we're going to use software to help us extract more data from that imaging. So what I was kind of talking about earlier is currently the availability of imaging is not as well known, something we've looked at and we're trying to publish, but the availability of perfusion and MRI is low, actually. And so I think that what will end up winning is what people can do because that's what they have. Like the question from the international guest was, if you can't do MR perfusion or CT perfusion, are you at a disadvantage? And I think the answer is going to be no. We're gonna catch up with our ability to get what we need to from the readily available simplified imaging protocols.
Great. All right. Well, thank you so much again for a wonderful talk, and thank you to all the participants for their excellent questions.